Welcome to Bookfulness. This is episode 27, continuing our deep dive into clinically oriented anatomy.
That's right. Last time we really laid the groundwork, didn't we? We covered the bones of the lower limb, femur, tibia, fibula, the foot bones.
Yeah, the whole static architecture, how weight is transferred, common fractures, that sort of thing.
Exactly. The solid foundation.
Today we're shifting focus. We're looking at the soft tissues that support and enable everything, the fascia, the vessels, the nerves.
And how it all works together. Function is key today.
Right. So we'll explore those support systems, then get into biomechanics, posture, how we stand, and the really complex dance of walking, the gait cycle.
And finally, we'll tackle the muscles themselves, specifically the big groups in the anterior and medial parts of the thigh.
Moving from the blueprint to the actual moving machine. Let's get started.
Okay, first things first. The fascia. You can't understand the organization without it. You've got the superficial fascia, the fatty layer just under the skin with superficial veins.
But the really important one, structurally speaking, is the deep fascia, right? That tough, stocking-like layer.
That's the one. In the thigh, we call it the fascia lata. Below the knee, it continues as the crural fascia.
And it's not just a wrapper, is it? It actively organizes the muscles.
Absolutely. It forms these thick walls, or septa, that dive down between muscle groups, creating distinct compartments, anterior, medial, and posterior in the thigh.
That compartmentalization is huge, clinically too, thinking about compartment syndrome.
Precisely. If you get swelling inside one of those compartments, that rigid fascia doesn't stretch, and pressure builds up, potentially cutting off blood supply. It's a serious issue. The fascia lata itself is incredibly strong, especially laterally.
Which brings us to the iliotibial tract, or IT band. Everyone talks about it in relation to running or knee pain. What exactly is it anatomically?
Well, it's not just a separate band. It's actually a massive thickening and aponeurotic reinforcement of that fascia lata on the lateral side. And critically, it gets insertions from two muscles.
Which ones?
The tensor fasciae latae, the TFL, anteriorly, and a large part of the gluteus maximus posteriorly.
So it's under active muscular tension.
Constantly, especially during movement. It acts like a dynamic tension band down the side of the thigh, stabilizing both the hip joint and, importantly, the lateral side of the knee joint, particularly when you're standing on one leg.
Okay, that makes sense. So fascia organizes things.
Yeah.
Now let's talk about the supply lines of the vascular system. The main artery coming down is the femoral artery.
Yes, the femoral artery starts just after the inguinal ligament, continuing from the external iliac. That's the main highway, you could say.
But does it supply everything directly, especially those deep thigh muscles?
Not primarily. Its most important branch, the one that does the heavy lifting for the thigh muscles, is the deep artery of the thigh, the profunda femoris.
The profunda femoris, okay. It dives deep, as the name suggests.
It does. It branches off the femoral artery quite high up in the femoral triangle and plunges deep, running behind the adductor longus muscle. And it gives off these crucial perforating branches.
Perforating branches, meaning they pierce through muscles.
They pierce through the adductor magnus muscle mainly, wrapping around the femur to supply muscles in all three compartments, anterior, medial, and posterior. It's the real workhorse for nourishing the bulk of the thigh.
So if the main femoral artery got blocked somehow, could these provide an alternative route?
To some extent, yes. There are connections and anastomoses, particularly around the hip joint, like the cruciate anastomosis. But the profunda femoris supplies the vast majority of the blood under normal circumstances. Its perforating branches are vital.
Okay, arterial supply covered. Now, getting the blood back out the venous drainage, it's a bit more complex, isn't it? Two systems.
That's right. You have the superficial veins running in that superficial fascia outside the deep fascia. The main ones are the great and small saphenous veins. They don't directly follow the major arteries.
And then you have the deep veins.
Yes, the deep veins run alongside the major arteries beneath the deep fascia. So you'll have femoral veins, profunda femoris veins, popliteal veins, tibial veins, mirroring the arterial tree.
What's the key functional difference between these two systems, especially regarding getting blood back up against gravity?
Valves. Both systems have valves to prevent backflow, but the crucial point the book emphasizes is that the valves are far more numerous in the deep veins.
More numerous in the deep system. Why is that so important?
Because of the muscle pump. The deep veins are nestled within the muscle compartments. When you walk, contract your calf muscles, your thigh muscles, they squeeze those deep veins.
Like squeezing a tube.
Exactly. And because of all those closely spaced valves, the blood can only be squeezed upwards towards the heart. It can't flow back down. That muscular compression is the main engine driving venous return from the legs.
So the superficial veins don't get that same pumping action.
Not really. They collect blood from the skin and superficial tissues and then drain into the deep system via perforating veins. But the heavy lifting, about 90% of the venous return, is handled by that deep system and its highly effective muscle pump, thanks to all those valves.
Makes sense why deep vein thrombosis, a clot in the deep system, is such a big deal then. It affects the main drainage pathway.
Absolutely. And if the valves in the deep veins fail, the muscle pump becomes inefficient, leading to blood pooling, swelling, and chronic venous insufficiency.
Okay, fascinating detail about the valves. Let's move to another fluid system, the lymphatics. Where does the lymph from the lower limb end up?
The main collection points are lymph nodes clustered in two key areas. The popliteal fossa, behind the knee, and the inguinal region, in the groin.
The popliteal nodes drain the knee area mostly?
Yeah, the knee joint itself and some of the lower leg structures. But the inguinal lymph nodes, especially the superficial inguinal nodes, are clinically really significant. They drain a huge territory.
Right, that's what's striking. They don't just drain the leg.
Not at all. They receive lymph from the entire lower limb, essentially,
Yeah.
but also the skin of the lower abdominal wall, the perineum, the external genitalia, vulva, scrotum, penis, and even the lower part of the anal canal.
So if someone comes in with swollen, tender lymph nodes in their groin inguinal lymphadenopathy,
You have to cast a wide net diagnostically. The infection or inflammation or even a tumor spreading could be anywhere from the medial side of their foot up the leg, or it could be originating in the perineum, the genitals, or the lower trunk. It's a major crossroads.
a real diagnostic hub.
Okay, shifting to nerves now. The skin sensation, cutaneous innervation. The book talks about two different ways to map this out.
Yeah, this can be a bit confusing initially. You have the dermatome map, which shows the area of skin supplied by a single spinal nerve root, like L2, L3, L4. This reflects the segmental origin from embryonic development.
And that's useful for pinpointing spinal cord or nerve root injuries.
Exactly. But then you have the peripheral nerve distribution map. Nerves coming off the spinal cord mist together in plexuses, like the lumbar and sacral plexuses, and form new multi-segmental peripheral nerves that travel down the limb. These nerves supply specific territories of skin.
So the area supplied by, say, the femoral nerve doesn't perfectly match a single dermatome. Generally, no. A peripheral nerve usually contains fibers from multiple spinal levels. We need to know both maps. For example, take the lateral cutaneous nerve of the thigh.
Okay, what's its story?
It comes from spinal roots L2 and L3, but its peripheral distribution is purely sensory to the skin on the anterior and lateral aspects of the thigh. Nothing else.
And that's clinically relevant for conditions like neuralgia paresthetica.
Precisely. That's compression of that specific peripheral nerve, often as it passes under the inguinal ligament. It causes burning, tingling, numbness just in that lateral thigh area, the nerve's territory, even though the L2 and L3 nerve roots themselves might be perfectly fine.
Got it. What about another key one, like the saphenous nerve? We mentioned it briefly earlier.
Right. The saphenous nerve is actually the terminal sensory branch of the femoral nerve. It originates from L3 and L4 spinal levels. It travels down the thigh through the adductor canal, but then continues superficially to supply sensation to the medial side of the leg and the medial side of the foot. A long course.
And posteriorly.
The posterior cutaneous nerve of the thigh is a major player there, coming from S1, S2, and S3. It supplies the skin on the back of the thigh and down into the popliteal fossa. So you really need both maps, dermatomes for spinal level, peripheral nerves for specific nerve injuries.
Okay, let's switch gears dramatically. From these detailed maps to how we simply stand still. Relaxed standing. The book says it's surprisingly efficient.
It is, thanks to biomechanics. When you stand relaxed, at ease, your hip joints and knee joints are fully extended.
Locked out, essentially.
Pretty much. In full extension, the ligaments around these joints become taut. Think of the strong iliofemoral ligament at the hip, the Y ligament. It screws the femoral head into the acetabulum, creating inherent stability. The knee ligaments are also taut. This means minimal muscle activity is needed just to keep the hip and knee extended. You're kind of hanging on your ligaments.
So if the hip and knee are relatively stable passively, where's the main challenge to balance?
It's the ankle joint. The body's overall line of gravity when standing relaxed typically falls slightly anterior to the axis of rotation of the ankle joints.
Meaning we have a natural tendency to fall forward.
A slight constant tendency to sway forward, yes.
So what stops us from just tipping over?
Your calf muscles, primarily the soleus and gastrocnemius, the plantar flexors. They have to contract periodically and subtly, but constantly.
How are they contracting? Concentrically pulling us back.
Actually, mostly eccentrically. As you sway slightly forward, gravity stretches the calf muscles. Their reflex contraction resists that stretch, pulling your center of gravity back over your ankles. It's a continuous, fine-tuning process.
A constant little dance of forward sway and calf muscle correction. What about side-to-side sway?
Lateral stability relies more on the hip abductors, muscles like the gluteus medius and minimus, and importantly, the tensor fasciae latae, acting through that iliotibial tract we discussed earlier. They contract to counter any lateral sway and keep the pelvis stable over the supporting leg or legs.
So even standing still isn't truly still. There's this constant low-level muscular activity, especially at the ankles and hips.
Exactly. Minimal but essential for maintaining upright posture.
Okay, from standing still to moving the gait cycle, walking. It seems simple, but anatomically it's incredibly complex.
It really is a beautifully coordinated sequence of events.
Yeah.
We define one full gait cycle from the moment one foot hits the ground, initial contact or heel strike, to the next time that same foot hits the ground again.
And it's divided into two main phases for each leg, right?
Right. The stance phase, when the foot is on the ground, which makes up about 60% of the cycle typically, and the swing phase, when the foot is off the ground and advancing forward, about 40%. There's also a period of double support, where both feet are briefly on the ground.
Let's break down the stance phase first. It starts with heel strike. What's critical there?
At heel strike, you need to control the impact. The key muscles here are the dorsiflexors of the ankle, the tibialis anterior, and the toe extensors.
But they lift the foot up. Why are they active when the heel is hitting down?
They're contracting eccentrically. As your heel hits, gravity and momentum want to pull your forefoot down rapidly, slapping it onto the ground. The dorsiflexors contract eccentrically. They lengthen, while resisting, to lower the forefoot smoothly and controllably.
Ah, so they act like brakes for the forefoot?
Exactly. It absorbs shock and ensures a smooth transition. If those muscles are weak or paralyzed, you get foot drop. And the person has that characteristic foot slap with each step because they can't control that descent.
Okay, after the foot is flat, we enter the loading response. What's happening then?
Now, the full body weight is being transferred onto that limb. The major challenge is preventing the knee from collapsing into flexion under that load. So the quadriceps fire powerfully.
The big thigh muscles contract strongly to keep the knee straight, or slightly flexed but stable.
Exactly. They absorb shock and provide stability as the body's momentum carries it forward over the planted foot.
Then comes mid-stance. This is when the other foot is swinging through, so you're balancing entirely on one leg. Stability must be key here.
Paramount. And this is where the hip abductor muscles on the stance leg, the leg on the ground, do their most crucial work. The gluteus, medius, and minimus.
What are they doing? They aren't moving the stance leg itself, are they?
No. They are contracting powerfully to stabilize the pelvis. When you lift one leg off the ground, gravity wants to pull the pelvis down on that unsupported side. The abductors on the stance side contract to pull the pelvis up on the stance side, effectively keeping the pelvis level.
So they prevent the hip from dropping on the side that's swinging through?
Precisely. If those abductors are weak, the pelvis drops on the swing side. That's the positive Trendelenburg sign you see clinically. It forces the person to lurch their trunk over the stance leg to compensate the Trendelenburg gait or abductor lurch.
Maintaining that level pelvis is essential for the swinging leg to have enough room to clear the ground, I imagine.
Absolutely. Without that abductor stability, normal gait breaks down. Then as the body moves past the stance foot, we get into terminal stance and pre-swing, or push-off.
This is where the calf muscles finally get to propel us forward.
Yes. Now the plantar flexors gastrocnemius and soleus contract concentrically, pushing down through the ball of the foot to propel the body forward and upward, initiating the swing phase to that leg.
Okay, so the leg is pushed off, enters the swing phase. What's the first priority?
Clearing the ground. You need to lift the foot so it doesn't drag or catch. So the dorsiflexors tibialis anterior, again, now contract concentrically to lift the toes and foot up.
So eccentric at heel strike to control descent, concentric in swing to lift the foot.
You got it. If they're weak, the person might have to excessively flex their hip and knee to lift the leg higher to clear the foot a steppage gait.
Now, here's the part you hinted at earlier. The end of the swing phase, terminal swing, just before the heel strikes again. What's happening?
This is fascinating and maybe counterintuitive. As the leg swings forward, it builds up momentum. If you just let it swing freely, it would crash down hard and probably overshoot.
So something needs to put on the brakes.
Exactly. And the main brakes are the hamstrings and, to some extent, the gluteus maximus.
But they're hip extensors and knee flexors. Why are they active when the leg is swinging forward into extension?
They contract eccentrically again. They are actively lengthening while resisting the forward momentum of the swinging limb. They decelerate the thigh and leg, controlling the end of the swing so the heel can be placed precisely and gently for the next heel strike.
So in normal walking, the hamstring's peak activity isn't pushing you forward, but rather slowing the leg down just before impact.
That's a key takeaway. In sprinting, yes, they are powerful extensors propelling you, but in walking, their crucial role is this eccentric braking action in terminal swing. It ensures smoothness and control. It's really elegant.
Wow. Okay, that really highlights the complexity. Let's dive into the muscles responsible for some of these actions, starting with the anterior thigh compartment.
Right. As we said, the thigh is divided into three compartments by fascia. The anterior compartment primarily contains muscles that flex the hip and extend the knee, and they're generally innervated by the femoral nerve.
The big hip flexor everyone knows is the iliopsoas, right?
Correct. It's technically two muscles, the psoas major coming off the lumbar spine and the iliacus lining the inside of the ilium that merge into a common tendon, inserting on the lesser trochanter of the femur. It's the most powerful flexor of the thigh at the hip joint.
So it's key for initiating the swing phase of gait.
Absolutely.
Yeah.
But it also works when the thigh is fixed. If you're lying down and do a sit-up, the iliopsoas contracts to flex the trunk on the fixed thighs.
And people often strain their lower back doing sit-ups incorrectly because they overuse the iliopso.
Yeah, because it pulls directly on the lumbar vertebrae. Excessive or improper use can definitely contribute to low back pain. It also has an important eccentric role.
When?
When you're walking downhill or going downstairs, gravity wants to pull your trunk forward and flex your hip rapidly. The iliopsoas contracts eccentrically to control that rate of hip extension, preventing you from just collapsing forward.
Okay, the other huge muscle group in the anterior thigh is the quadriceps femoris.
The quads, four heads: rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, deep to the rectus. They all converge onto the common quadriceps tendon, which incorporates the patella, kneecap, and then continues as the patellar ligament to attach to the tibial tuberosity.
Their main action is knee extension.
Powerful knee extension, yes. Critical for standing up, walking, running, jumping. The rectus femoris is unique because it crosses both the hip and knee joints.
So it also helps flex the hip.
It does. It assists the iliopsoas in hip flexion, especially when the knee is flexed. The vasti muscles only act on the knee.
The book mentions the lower fibers of the vastus medialis and lateralis being particularly important for knee stability. Why those specific fibers?
They're referring particularly to the oblique fibers of the vastus medialis, sometimes called the VMO, vastus medialis obliquus. Because the overall line of pull of the quadriceps tends to pull the patella slightly laterally, the VMO fibers have a more horizontal orientation. Their job is to pull the patella medially, counteracting the lateral pull and keeping the patella tracking properly in its groove on the femur during movement.
So weakness in the VMO can lead to kneecap tracking problems and pain.
Very common cause of anterior knee pain, yes. That's why VMO strengthening is often a focus in knee rehab.
Are there any other muscles in the anterior compartment we should mention?
Yes, the sartorius. It's the longest muscle in the body. A strap-like muscle that runs obliquely across the front of the thigh, from the anterior superior iliac spine down to the medial side of the tibia.
The Taylor's muscle.
That's the nickname, supposedly from the cross-legged sitting position tailors used. It's a bit of a weak muscle overall, but it contributes to several actions: hip flexion, abduction, and lateral rotation, as well as knee flexion. It acts across two joints.
And the pectineus. Sometimes it's grouped here, sometimes medially.
It's sort of transitional. It lies quite anteriorly and medially. It primarily adducts the thigh, but also assists in hip flexion. So it has actions relevant to both compartments.
Okay, that covers the anterior compartment well. Let's move to the medial thigh compartment. These are mainly the adductors.
Predominantly, yes. The main players are the adductor longus, adductor brevis, and the large adductor magnus. You also have the slender gracilis muscle running down the medial side. They all generally originate from the pubis and ischium and insert along the linea aspera of the femur, except for gracilis, which crosses the knee.
Their main job is adduction, pulling the thigh towards the midline. Why is that functionally important?
It's crucial for stability, especially during walking or activities requiring balance. When you're in the single stance phase of gait, the adductors on the stance leg work together with the abductors on the opposite leg to stabilize the pelvis in the frontal plane. They also help control movements like kicking a ball across your body or, classically, gripping the saddle when riding a horse.
And the gracilis crosses the knee.
Yes, it inserts down on the medial tibia, along with the sartorius and semitendinosus tendon, forming the pes inserenus. So it also assists in knee flexion and medial rotation of the flexed knee.
Is there anything else deep in the medial compartment?
There's the obturator externus. It's a deep fan-shaped muscle arising from the external surface of the obturator membrane and surrounding bone. It passes posteriorly under the hip joint to insert near the greater trochanter.
And its main action.
Powerful lateral rotation of the thigh at the hip joint.
Okay, now for a really important anatomical region that brings together structures from these compartments. The femoral triangle. Where exactly is it?
It's a triangular space in the upper anterior part of the thigh, just below the inguinal ligament.
And what defines its borders?
The inguinal ligament forms the superior base. The medial border is the medial edge of the adductor longus muscle. The lateral border is the medial edge of the sartorius muscle. The floor is formed by muscles like the iliopsoas laterally and pectineus medially.
And the crucial contents. There's a useful mnemonic, isn't there?
Yes, from lateral to medial, it's navel, femoral nerve, femoral artery, femoral vein, empty space, the femoral canal, and lymphatics within the canal, often simplified to NAV for the main structures. Nerve, artery, vein, lateral to medial.
Nerve, artery, vein. That order is consistent.
Very consistent and clinically vital for accessing these structures, like for taking a femoral pulse or gaining venous access.
Now, you mentioned the femoral canal as part of that, and the femoral sheath. How do they relate to the artery and vein?
Okay, the femoral sheath is a downward projection of the fascia from the abdomen that surrounds the femoral artery and vein as they pass under the inguinal ligament into the triangle. It's like a fascial sleeve.
Does it surround the nerve, too?
No, and this is a critical point. The femoral nerve lies lateral to the sheath. Outside of it, nestled between the psoas and iliacus muscles.
So the sheath only encloses the artery and vein.
And the femoral canal. The sheath is divided internally into 3 compartments. The lateral one holds the artery, the intermediate one holds the vein, and the most medial compartment is the femoral canal.
What's in the femoral canal? You mentioned empty space and lymphatics.
It's a small space, maybe a centimeter long, containing some loose connective tissue, fat, and crucially, deep inguinal lymph nodes and lymphatic vessels. Its upper opening into the abdomen is called the femoral ring.
And this femoral canal and ring are important because of hernias.
Exactly. The femoral canal is a potential weak spot in the abdominal wall. A femoral hernia occurs when abdominal contents, like a loop of intestine or omentum, push through the femoral ring and down into the femoral canal, appearing as a bulge in the groin, typically below the inguinal ligament.
The book notes these are more common in females?
Yes, potentially due to the wider female pelvis and maybe changes during pregnancy and childbirth.
And importantly, femoral hernias are considered more dangerous than the more common inguinal hernias. Why is that?
Because the boundaries of the femoral ring are very rigid and unyielding. You have the strong inguinal ligament anteriorly, the lacunar ligament medially, a sharp edge of connective tissue, the pectineal ligament posteriorly, and the femoral vein laterally. There's no give.
So if bowel protrudes through that tight ring,
It's very easily compressed, cutting off his blood supply. This is called strangulation. The risk of strangulation is much higher with femoral hernias compared to inguinal hernias.
making it a surgical emergency.
Absolutely. Strangulated hernia requires immediate surgery to restore blood flow and repair the defect. Otherwise, the trapped tissue will die.
And speaking of surgery near the femoral ring, there's an anatomical variation surgeons need to be aware of.
Yes, a really important one. The replaced or accessory obturator artery.
What is that?
Normally, the obturator artery arises from the internal iliac artery within the pelvis. But in about 20% of people, an enlarged pubic branch from the inferior epigastric artery, which runs near the inguinal region, either takes over the supply territory of the obturator artery, replaced, or runs alongside it, accessory.
Okay, so an artery in an unusual place. Why is it dangerous during hernia repair?
Because this variant artery often runs very close to or even across the medial margin of the femoral ring, right where a surgeon might be placing sutures or staples to repair a femoral hernia.
Oh, wow. So they could easily damage it if they aren't aware it might be there.
Exactly. Injuring it can cause significant bleeding, hence its rather grim nickname among some surgeons, the corona mortis or crown of death. It's a critical anatomical variation to anticipate.
A real high-stakes situation. Okay, let's follow the main vessels further down the thigh. They enter the adductor canal.
Yes, After leaving the apex of the femoral triangle, the femoral artery and vein, along with the saphenous nerve, enter the adductor canal, also known as Hunter's canal, or the subsartorial canal.
Where is this canal located?
It's an intermuscular passage deep to the sartorius muscle in the middle third of the thigh. It runs from the apex of the femoral triangle down to an opening in the adductor magnus muscle called the adductor hiatus.
So it's a protected tunnel for the neurovascular bundle.
Precisely. It guides the main vessels safely towards the back of the knee.
And what happens at the end of the canal, at the adductor hiatus?
The adductor hiatus is an opening in the tendon of the adductor magnus muscle, near the femur. The femoral artery and vein pass through this hiatus to enter the popliteal fossa, the space behind the knee.
And when the artery passes through, it changes name.
Yes, as soon as the femoral artery exits the adductor hiatus, it becomes the popliteal artery. Same vessel, different name based on location.
What about the saphenous nerve? Does it go through the hiatus too?
No, this is another key detail. The saphenous nerve travels through the adductor canal alongside the vessels, but it does not pass through the adductor hiatus with them.
So where does it go?
It pierces the fascial roof of the canal more anteriorly, passes between the sartorius and gracilis muscles, becomes superficial, and continues down the medial side of the knee and leg to provide skin sensation, as we discussed earlier. It takes a different exit route.
Got it. Okay, let's wrap up with some clinical correlations mentioned in the text, particularly regarding swellings in the groin area. A psoas abscess can mimic other things.
Yes, it's a classic mimic. A psoas abscess is a collection of pus within the fascia covering the psoas major muscle. It usually results from infection spreading from elsewhere, often tuberculosis of the lumbar vertebrae, or sometimes from Crohn's disease or other abdominal infections.
And because the psoas muscle extends down into the thigh.
The pus tracks down along the muscle within its fascial sheath, passing under the inguinal ligament. It can then present as a swelling in the groin, in the femoral triangle area.
So it could easily be mistaken for a hernia.
Definitely. It's on the differential diagnosis list for any groin swelling, along with inguinal hernia, femoral hernia, enlarged lymph nodes, or even something like a saphenous varix.
What helps differentiate it?
The history might suggest infection, fever, back pain, history of TB or Crohn's. Sometimes on examination you can detect fullness in the iliac fossa as well. It might also cause pain with hip extension, which stretches the psoas.
What's a saphenous varix?
A varix is a localized dilation, like a bulge or aneurysm, of a vein. A saphenous varix specifically refers to a dilation of the very top end of the great saphenous vein, right where it joins the femoral vein in the femoral triangle.
So it also causes a swelling in the groin.
Yes, often a soft, compressible swelling. The key feature is often its behavior. It might fill when the person stands or coughs, increasing venous pressure, and typically disappears or reduces significantly when they lie down and elevate the leg.
And you'd likely see other varicose veins in the leg.
Often, yes. That association helps distinguish it from a hernia, which usually feels firmer and might not reduce so easily, especially if strangulated, or from an abscess, which is typically tender and non-reducible.
Okay, so careful examination and history are key. Finally, connecting back to surface anatomy, finding the femoral pulse is easy, but the vein isn't palpable. How do you reliably locate the femoral vein for access?
You use the artery as your landmark, and remember the NAV relationship. Palpate the femoral artery pulse, it's usually strong, found just below the midpoint of the inguinal ligament. The femoral vein lies immediately medial to the artery.
So find the pulse, move slightly medial, and that's where the vein should be.
That's the standard approach for locating it safely for procedures like central line insertion.
Excellent. That brings us to the end of this section. We've covered a lot of ground today.
We certainly have.
We examined the fascial layers that organize the thigh, traced the major arteries, veins, lymphatics, and nerves, including that crucial femoral triangle and adductor canal region. We looked at the biomechanics of standing, unpacked the really intricate muscle actions during the gait cycle, and detailed the muscles of the anterior and medial thigh compartments.
Next time, we'll complete our tour of the thigh and hip by moving posteriorly. We'll explore the powerful gluteal muscles, including the gluteus maximus and the posterior thigh compartment, focusing on the hamstrings.
And here's a final thought to ponder, building on that gait discussion. In your everyday walk, the massive gluteus maximus, your body's strongest hip extensor, is relatively quiet. It's the hamstrings doing significant work. But their peak effort isn't pushing you forward. It's that eccentric contraction, actively breaking your swinging leg just before your heel hits the ground. Think about that tiny, controlled deceleration. It's arguably one of the most critical, finely tuned neuromuscular events happening with every single step you take.
Thanks for listening to Bookfulness.